All right, people, today we are going to discuss a very important topic, that is Zenker Diverticulum. This one is very high yield for USMLE and other competitive exams. So first we'll start with the name itself. Why is it called Zenker Diverticulum? It's called Zenker because it is named after a German pathologist, Friedrich Albert von Zenker, who first described this condition. Now, what is exactly Zenker diverticulum? So basically, it is a pharyngoesophageal false diverticulum. False diverticulum means that not all the layers of the pharyngeal wall herniates out, but only mucosa and submucosa herniates through the defective wall. So it's called false diverticulum. And it is caused by dysfunction of pharyngeal muscles or esophageal dysmotility, which can lead to pressure buildup during swallowing. And this in turn leads to herniation of mucosal tissue at an area of weakness between the thyropharyngeus and cricopharyngeus, which are the parts of inferior pharyngeal constrictor, and the defective area between the thyropharyngeus and cricopharyngeus is a triangular defect known as Killian triangle. So what are the presenting symptoms? It presents clinically as dysphagia, means difficulty in swallowing, especially for solids first and then liquid. There can be obstruction in the outflow tract. Also, when the patient takes liquid, gurgling sound can be heard. It can also lead to bad breath or halitosis due to food getting stuck inside the pouch. And the patient also presents with the neck mass, or there may be a sensation of foreign body in the neck known as globus. Also, there is the risk of aspiration leading to aspiration pneumonia. One tips that this Zenker diverticulum can be mistaken for oropharyngeal cancer on barium swallow. So always know barium swallow shows outpouching posteriorly on imaging. Next, we have the diagnosis of Zenker diverticulum. So the best initial test can be barium swallow study, which shows posterior outpouching at the pharyngoesophageal junction. Also, we can do endoscopy, but remember, the endoscopy should be done very cautiously because there is increased chance of perforation of the pouch while putting the instrument inside. Now, the management of Zenker diverticulum. Management can be done by seeing two phases, that is, it's symptomatic or asymptomatic. If it's asymptomatic and small, less than 2 centimeter, we can just wait and watch. But if it starts to develop symptoms, or it grows large, more than 2 centimeter, then we can go for endoscopic cricopharyngeal myotomy, which is the first line, and it is minimally invasive. It can include diverticulotomy and stapling. And next option is we have surgical or open diverticulectomy. This is done if endoscopy is not feasible, or if endoscopy fails, or if the pouch is very large. So finally, one final key point, cricopharyngeal myotomy is essential to relieve the underlying muscle dysfunction and prevent recurrence in the future. So finally, here is one image showing the herniation from the defective wall, that is Killian triangle. This one is the thyropharyngeus muscle. This one below down here is cricopharyngeus muscle. So between these two muscles, there is one defective area or triangular in shape. That's why it's called Killian triangle. And from this defective triangular area, the diverticulum develops. That is the false diverticulum. It bounces out from this defective wall, and this is Zenker's diverticulum, and this is esophagus, and this is trachea. So this is how it develops. Alright, this much for now. Thank you for watching. Take care. Bye.